This eHIV review program is presented by DKB Med Radio.
Most of our guidelines around HIV and comorbidity management are HIV acquisition neutral, meaning recommendations exist for everyone, regardless of the HIV source. Sometimes it can be helpful to understand the mechanism of HIV acquisition because it could change my approach to certain screening practices like sexually transmitted infection testing or recommendations for specific vaccines. But in the era of undetectable equals untransmittable, this is less of an issue.
Managing HIV-related comorbidities in an aging population. Welcome to eHIV Review. Older people living with HIV. They share many of the same age-related ailments as their HIV seronegative peers. But the combined effects of HIV, ART, and aging bodies and minds require different treatments. What medications may affect seniors living with HIV differently? Which cancers are seniors living with HIV more prone to? What do clinicians need to know to better recognize these risks? What does the current evidence say about the advances in managing them? And how can those new data best be applied in the clinic right now? To discuss these concerns, we're joined today by Dr. Maile Young Karris. She's co-director of the San Diego Center for AIDS Research Clinical Investigations Core and an associate professor in the divisions of infectious diseases and global public health and geriatrics, gerontology, and palliative care in the Department of Medicine at UCSD, the University of California, San Diego. For our guest disclosure and additional CME information, please visit our website, ehivreview.org, and select the Volume 10, Issue 4 link. I'm Bob Busker, Executive Producer of DKB Med's e-Literature Review video programs. Dr. Karris, thank you for joining us today.
Thank you for the opportunity to chat.
Our overall learning objective for today's program is to evaluate strategies to mitigate the effects of comorbidities in older people living with HIV. The focus of this first part of our conversation is to describe the potential benefits versus the side effects of the GLP-1RA class of medications to manage common comorbidities of HIV. So if you would please, Dr. Karris, start us out in a clinic with a patient scenario.
Sure. A 67-year-old woman has been living with HIV for about 35 years. 6 years ago, she switched from efavirenz, FTC, tenofovir disoproxil to an integrase inhibitor-based regimen with tenofovir alafenamide and FTC. Since her antiretroviral therapy switch, she started to slowly gain weight, but now has accumulated an additional 25 pounds and her body mass index is 30. She's not very active because her knees ache all the time, and over the last year, her blood work has demonstrated elevated glucose and liver enzymes 2 times the normal range, as well as a slowly downtrending kidney function, with a current glomerular filtration rate of 65. Currently, she has a hemoglobin A1C of 6%. A recent ultrasound of her liver demonstrates steatohepatitis.
Since her ART switch, as she's aged, she's shown several new comorbidities: obesity, steatohepatitis, prediabetes, and a potential warning signal for kidney damage. Where would you start, Dr. Karris, in an elderly patient living with HIV who's presenting with symptoms like these?
So several approaches exist, including lifestyle modifications such as a change in her diet, increased exercise, which we would hope would lead to weight loss. The first approach may also result in improvements in her pain and her physical function.
Well, all true, certainly. But we know the success rate of diet and exercise alone is notoriously low for weight loss, and that's particularly true for postmenopausal women. So let's assume this patient tried diet and exercise, but did not achieve adequate weight loss success. What would be your next step?
So we could treat each condition separately. We could do metformin for her, what looks like prediabetes. We could use a glucagon-like peptide-1 receptor agonist, the GLP-1RAs for weight loss, and vitamin E plus resmetirom, which activates thyroid hormone receptor beta in the liver for her steatohepatitis. However, one primary concern in the care of older adults is polypharmacy, or taking lots of different medications, because taking multiple medications can increase side effects and adverse events. They can contribute to drug-drug interactions and drive up medical costs. In this patient's case, we could consider, along with some lifestyle modifications, just starting a GLP-1 RA, specifically in the context of the slim liver study.
Talk to us about slim liver, if you would, please, Dr. Karris. What are the key highlights?
So slim liver is the first study to evaluate the GLP-1 RA semaglutide as a treatment for MASLD, specifically among people living with HIV.
MASLD. Please define that for us.
Metabolic dysfunction associated steatotic liver disease. It was previously known as non-alcoholic fatty liver disease, but MASLD is more common among people living with HIV than in the general population, and it may act synergistically with HIV and other common comorbidities like hepatitis B and C to accelerate liver injury and organ dysfunction. All the people enrolled in the slim liver study were adults living with HIV who were virally suppressed and had increased waist circumference, insulin resistance, or prediabetes, and steatotic liver disease. Of particular interest, 82% were on antiretroviral therapy that included an integrase inhibitor.
An integrase inhibitor, which is what the patient we've been discussing was switched to. Interesting. What can you tell us about the key results of slim liver?
In the slim liver study, low-dose semaglutide was associated with significant improvements in weight, waist circumference, fasting glucose, body mass index, hemoglobin A1C, ALT, and triglyceride concentrations within the liver.
So prescribing a GLP-1 RA agent would seem to be best for this patient, particularly now with the recent approval of semaglutide for MASLD. A question, Dr. Harris. How would your recommendation change if her A1C indicated diabetes instead of prediabetes?
It might make me even more likely to consider it, as GLP-1 RAs in older adults with diabetes has resulted in improved diabetes management, weight loss, and reduced major adverse cardiovascular events primarily. There's some evidence of renal protection as well. I would also discuss the sodium glucose cotransporter 2 inhibitors, or the SGLT2, with the patient. These agents also reduce MACE, heart failure hospitalizations, and renal outcomes. And our patients have preferences, and my patient's preferences and values are often different than mine. And in this case, she may be less concerned about her weight, but more concerned about the risk of future kidney disease. And then this is shared decision-making. And study after study has shown that it's clearly associated with improved patient-reported health outcomes and quality indicators.
Monitoring the effects of GLP-1 RA in older adults living with HIV? What does slim liver tell us?
So the slim liver study also measured psoas muscle volume and physical function.
The psoas muscle?
The psoas is a long, ribbon-shaped muscle in the lumbar region. It's one of the core muscles in the lower back. They found that psoas muscle volume decreased, but without any change in psoas muscle fat.
What does that mean in terms of patient comfort and safety?
Researchers often use psoas muscle volume as a surrogate marker for sarcopenia because of observed correlations with frailty and other clinical outcomes like post-op recovery. Sarcopenia is defined as muscle wasting that leads to a decline in physical functioning. Interestingly, other physical function assessments showed non-significant improvements in chair rise and gait speed, as well as significant decreases in the proportion of persons with low gait speed. So slim liver was a single-arm study among patients with HIV and metabolic syndrome. We do not yet have enough data to support the safety of this approach in underweight people with HIV.
Thank you, Dr. Karris, for sharing your knowledge and expertise on this important topic. Our key learning focus for this part of our discussion is describe the potential benefits versus the side effects of the GLP-1 RA class of medications to combat common comorbidities of HIV. What are the most important concepts you'd want our learners to take back to their practices?
Well, the first thing I would want our learners to take back is that weight gain commonly occurs in older patients on antiretroviral therapy, especially those on ART regimens that include an integrase inhibitor and TAF, possibly due to the weight suppressive effects from their predecessor drugs like efavirenz and tenofovir disoproxil. Next, the first of its kind slim liver study found low-dose semaglutide, a GLP-1 RA, was associated with significant improvements in weight circumference, fasting glucose, BMI, hemoglobin, A1C, ALT, and intrahepatic triglyceride concentrations. Polypharmacy is a danger in the care of all older adults because taking multiple medications can increase side effects and adverse events. Non-pharmacologic approaches can benefit conditions like cardiovascular disease, diabetes, steatohepatitis, and osteoporosis, and should be included in routine discussion with all of our patients. Next is shared decision-making in healthcare is critical to improving adherence as well as patient-reported health outcomes and quality indicators. And as one final key takeaway, in older adults, HIV care now is comorbidity care.
Nice summation, Dr. Karris. Thank you. And we'll return with the co-director of the San Diego Center for AIDS Research Clinical Investigations Core, Dr. Maile Young Karris, in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program. Our guest is Dr. Maile Young Karris from the Department of Medicine at the University of California, San Diego. Our overall learning objective is how to evaluate strategies to mitigate the effects of comorbidities in older people living with HIV. In the first part of today's program, we discussed the potential benefits versus the side effects of the GLP-1 RA class of medications to combat some of the common comorbidities of HIV seen in older patients. Let's look now at the second focus of today's program. Explain how recent changes in published HIV guidance indicate the need for increased preventative anal cancer testing. So if you would please, Dr. Karris, take us back to the clinic with another patient scenario.
Sure. A 63-year-old man was referred to the HIV clinic following a new diagnosis of AIDS, CD4 T cells 150, following 6 months of an extensive workup for weight loss. He reports he really doesn't know how he got HIV. He's never been tested before because he's been married for 40 years, never received a blood transfusion, no injection drug use, and no accidental needle stick. He and his wife have 3 children, all of whom are now healthy adults. He does endorse that prior to marriage, he had 2 sexual partners, but that his wife tested HIV negative. He has no other chronic conditions as he's been an avid runner all his life. He reports that he is feeling a lot better on his antiretroviral therapy and that he's happy to see his HIV viral load decreasing. His wife dutifully sits in the exam room with a pen and paper in hand and reports that he has a great primary care physician and his health maintenance is completely up to date.
So this patient, whose CD4 T cell count was low enough for an AIDS diagnosis, endorses none of the common routes of HIV acquisition. How would you account for the source of his infection?
HIV is still an incredibly stigmatizing condition, and patients may not be ready to talk about sensitive topics with a new doctor, especially on the first visit. Most of our guidelines around HIV and comorbidity management are HIV acquisition neutral, meaning recommendations exist for everyone, regardless of the HIV source. Sometimes it can be helpful to understand the mechanism of HIV acquisition because it could change my approach to certain screening practices like sexually transmitted infection testing or recommendations for specific vaccines. But in the era of undetectable equals untransmittable, this is less of an issue.
Point taken, doctor. So back to the exam room. How would you approach this patient?
He may have an excellent primary care physician, but people with HIV are at increased risk for some specific conditions that I would also recommend screening for. The 2024 Department of Human Health and Services guidelines for the first time recommends anal cancer screening in all persons with HIV 45 years and older.
Well, just for clarity, doctor, that's screening for all persons with HIV, not just MSM with HIV. Is that right?
Correct. The guidelines recommend screening men who have sex with men and transgender women with HIV earlier at age 35.
Anal cancers, are they like cervical cancers in the sense that they're primarily caused by HPV, the human papillomavirus?
This is also correct. HPV-16 is the most common HPV type in anal cancers. It's found in about 73% of occurrences. But relative to the general population, people with HIV have an increased incidence of anogenital tumors and anal cancers. And the elevated risk of HPV-associated cancers in people with HIV continues into older age, meaning over 50 years. In addition, low CD4 T cell counts in people with HIV have also been associated with increased risk of anal cancer, as well as high-grade anal intraepithelial neoplasia, the likely anal cancer precursor lesion.
I think these anal cancer data and the recommendations for screening are going to come as a surprise to both clinicians and patients alike. Now, we talked about the need for shared decision-making in our previous case. So how would you pursue shared decision-making when you're discussing anal cancer with this patient on this first visit? Walk it through for us if you would, please, doctor. Should his wife step out for this part of the conversation?
When there's another person in the room, I start with saying my first visit is usually a one-on-one due to medical confidentiality, and then I wait on the patient's response. Many times, partners will leave the room for a sensitive exam, and that also might provide an opportunity to ask more direct questions, reassuring the patient that I will not tell their partner and I will respect their wishes if they do not want information recorded in the medical record. This patient wanted his wife in the room and said we could talk about anything.
And the next step?
Next step is to talk about HIV pathogenesis, specifically immunodeficiency, leading to increased risk of cancers caused by other infections. Related to HPV, I communicate that people with HIV have up to 2 times higher rates of HPV-associated cancers, cervical, anal, oral, because of HIV-associated immunodeficiency. I also comment that even if someone has never had anal sex, people can still be at risk for anal cancer. HPV is transmitted in fluids, and during sex, fluids go everywhere.
Overall, how has your approach to anal cancer screening changed since the current guidelines were created?
I'm fortunate that I have access in my clinical setting to anal cytology, and that's basically a pap smear for the anal canal. I also have access to standard anoscopy, which enables physicians to visually evaluate the anal canal, and as well as high-resolution anoscopy, or HRA, which integrates a magnifying colposcope and uses acetic acid solution to highlight abnormal areas, essentially mirroring cervical cancer approaches. I used to practice a shared decision-making approach based on cytology. Depending on the temperament of the patient, many preferred to pursue screening every 3 to 5 years or so. Because the impact of routine HRA was unclear, I really did let my patients drive decision-making unless they had symptoms.
And now?
My practice changed following the results of the Anal Cancer HSIL Outcomes Research Study, or the ANCHOR study. This randomized clinical trial of over 4,000 persons with HIV evaluated the impact of removal of high-grade squamous intraepithelial lesions, or HSIL, and future progression to cancer. ANCHOR demonstrated that treatment of persons with HSIL with high-resolution anoscopy reduced the risk of future anal cancer by 60%. With findings of this nature, how could I not strongly recommend screening and treatment? And when I provide those study results to patients, more are interested in pursuing screening and HRA. Our clinic has already recently added testing for high-risk HPV types that are associated with cancer, HPV 16 and 18, and a few other high-risk HPV subtypes. The current guidelines are helpful because they provide recommendations based on what resources are available in your particular clinical setting If you do not have access to cytology and or HPV testing, the recommendation is to refer to anoscopy or HRA if you have any symptoms like pencil-thin stools, bleeding, pain with anal sex, or abnormalities on the digital rectal exam, and that could be anal warts or other lumps and bumps.
Summarize for us, if you would please, Doctor, the key points of the new recommendations.
The guidance provides directions depending on the screening results. So first, if the patient doesn't have symptoms, has a normal digital rectal exam, and cytology is normal for 3 consecutive years, then repeat anal pap screening, which is cytology and high-risk HPV testing, in 3 years. If you're not seeing symptoms, the exam is negative, and your cytology and high-risk HPV tests are both negative, again, repeat anal pap screening in 3 years. If you have either normal cytology or atypical squamous cells of undetermined significance, also known as ASCUS, on anal pap, and HPV 16 and 18 are negative, then you can repeat the anal pap and HR HPV testing in 1 year. Nearly everything else goes to immediate HRA referral, including normal cytology with positive HPV 16 or 18, ASCUS and any positive HR HPV, and cytology showing low-grade or higher-grade squamous intraepithelial lesions, regardless of HPV status.
Excellent synopsis of the new guidance, Doctor. Before we wrap things up, anything else to add?
We've mostly focused on recommendations for adults, but I did want to highlight that the anal cancer prevention guidelines also recommend HPV vaccination for all people with HIV up to 26 years of age, usually 3 vaccine doses between the ages of 11 and 26 years. The current vaccine is approved for persons up to age 45 years, but vaccination is not currently routinely recommended. There may be specific contexts in which there could be value. For example, transitioning out of a long-term monogamous relationship into a period of greater sexual risk.
Thank you, Dr. Karris. Our key learning focus for this part of our discussion is to explain how recent changes in published HIV guidance indicate the need for preventative anal cancer testing in people living with HIV. What are the key things our learners need to know?
Okay, well, first, HIV confers greater risk for comorbidities like HPV-associated cancers, and as such, preventative guidance differs from the general population. Second, the ANCHOR study demonstrated that treatment of anal HSIL decreases future risk of anal cancer. This finding provides strong evidence for pursuing screening of all persons with HIV regardless of reported sexual history. Third, high-resolution anoscopy can be difficult to access, but current guidelines may assist providers in triaging whom should be referred. And know that standard anoscopy itself is also helpful. And last, HPV vaccination is recommended for all persons up to age 26, but is available for persons age 27 to age 45 based on shared decision-making.
From the Department of Medicine at the University of California, San Diego, and the San Diego Center for AIDS Research Clinical Investigations Corps, Dr. Maile Young Karris, thank you for sharing your knowledge and expertise with us in today's eHIV review program.
Thank you for inviting me. It's been my pleasure to be here.
For eHIV Review, I'm Bob Busker.